3. People would come at 4. Boss. Finally, I see the big boss, Amos. He went away. I called him boss, he got scared.
You scared him.
So good morning, good afternoon, good evening, everyone, depending on where you are joining us. I'm sorry, my connectivity has just gone down, so I hope I'm audible.
Yes, you are.
It's a warm welcome to all of us, participants and speakers in this inaugural webinar on the role of evidence in COVID-19 vaccine distribution in Africa. Welcoming you is Amos Jogona. I'm a professor of finance and I serve as the chair of the Network of Impact Evaluation Researchers in Africa. The Network of Impact Evaluation Researchers in Africa, NIERA, is an independent network of East African scholars who conduct decision-focused evaluation for social and economic development programs across Africa. And our work is driven on three key pillars, namely capacity building, where we build capacities of different audiences, program implementers, media practitioners, policymakers, researchers, and grant funders, many of them who are attending this webinar today. The second pillar is evidence generation. We seek to generate demand-driven research across different sectors, revolving around health, education, trade, that my friend Anthony, who is in this panel, leads, amongst other areas of interest to Africa. And lastly, we connect capacity building and evidence generation with policy outreach. Under this, we seek to engage with policymakers and intentionally promote the uptake of research evidence in policy decisions. We are privileged to have a diverse membership of multidisciplinary research expertise, some of whom will be sharing their insights today. I can already see Dr. Anthony Veyange, Dr. Sam Muhula, Dr. Janine Kondo, and many others who will be hosting us in coming webinars. Today's dialogue will shed light on how research evidence continues to inform policies and roll out different programs. In this case, the distribution of COVID-19 vaccine to different populations in Africa. Most importantly, we'll be sharing with you what we have learned and how the rollout of this particular vaccine program can inform our future programming, especially here in Africa. We heartily appreciate the partnership that we do have with different organizations. For example, IDinsight, who we are co-hosting this webinar. I will be introducing Dr. Frida Jogo very shortly. The Partnership for African Social and Governance Research, PASGAR, AMREF Health Africa, where my friend and brother hails from. That's Sam Muhula, who will also be talking to us today. AFIDEP, the Center for Impact, Innovation and Capacity Building for Health, Information Systems and Nutrition, amongst other partners who are not collaborating with us today, but will be collaborating with us in future discussions. Without much ado, I want to introduce Dr. Frida Jogo, who is the East African Regional Director for IDinsight, who will lead us into the next session. Dr. Frida Jogo is as I have mentioned, is the Regional Director. She is based in Nairobi. She's many things: a medical doctor, public health specialist, an entrepreneur, and development and management consultant. She's been in many places, so we'll be benefiting with her expertise and experiences, given her consulting stint at McKinsey and Company, company's Africa Delivery Hub. She served most recently as CEO and co-founder of Africa-18 Technologies, which is literally a Kenyan-based startup that built and operates a health analytics platform for health managers and service providers. It's important to note that Africa-18 Technologies was named by WHO as among the 30 top innovations with the highest potential for health impact in Africa. And she's been served for government, NGOs, civil society. Wow, I can't even name everything, especially with her exciting background in public health, her work on surrounding HIV, tuberculosis, maternal and child health, digital health, as well as public health, emergency financing, and operations. So, ladies and gentlemen, allow me now to hand it over to Dr. Frida Jogu, who is right there to take us through the next session. Dr. welcome.
Thank you, Prof, for the very warm introduction. Good afternoon, everyone. Afternoon, I think most people are afternoon, but also morning, evening, night, everybody. It's really an honor to be, co-hosting, but also, moderating today's webinar. About a topic that is very close to my heart for various reasons. So my name, as introduced, is Dr. Frida Jogu. My background is health. I'm actually a medical doctor, but I've spent most of my work working in public health. So as I said, this is a very a topic that is very close to my heart, having seen how lack of evidence can impact public health interventions and just availability and correct use of that evidence transforms health systems and really service delivery. And maybe I'll introduce IDinsight just very briefly. We are a global advisory, analytics, and research organization that helps development leaders maximize their social impact. So we tailor a wide range of data and evidence tools, such as randomized evaluations, machine learning, and others, to help decision makers design effective programs and rigorously test what works to support communities. So we are demand driven. We actually work from the needs of decision makers and then work to provide the data and evidence that they support. We work across Asia and Africa, and support leaders in the social space, and specifically I'm talking of governments, NGOs, funders, and to some extent social enterprises. And our work is in the social sectors, including education, health, agriculture, gender, livelihoods, financial inclusion, governance, and others. So I'm quite pleased to be, having this discussion, as we know that, testing and of course adequate public health interventions and vaccines are what will enable us to control the spread and the impact of the epidemic. And and as we can see, in some other countries, we managed to cover a significant proportion of the population, and that has resulted in a much lower disease burden of COVID-19. And globally, vaccines, about 38% of the population is vaccinated. In Africa, that number falls significantly. Only about 6.5% of the adult population is fully vaccinated. And in Kenya, we're not very far from that. We've recently, had an uptick in terms of vaccine uptake, with about 8.2% of the adult population fully vaccinated. But clearly you can see, we have quite a long way to go. We haven't started vaccinating teenagers or children who might still be, the drivers of the pandemic once we cover the adult population. And this low vaccination is for various reasons. And the one that we're going to focus on today is just really, access to the vaccine, which can be addressed through distribution partially. So really, vaccinations are low, and we have to optimize distribution and manage, the logistics thereof, including, trying to figure out, where are the most vulnerable. We have to avail vaccines where people are, and to ensure also there's, avoid wastages. And maybe some of us know that often vaccines come, a vial has got several doses, so how do you ensure that we don't have losses while ensuring that whoever comes does get the vaccine? So we have to match, in addition to some of the considerations around some of the considerations that we need to have even as we plan the logistics beyond where the people are, issues around wastage and loss, but also ensuring that you match the first and second dose, so you don't have AstraZeneca and Moderna subsequently. We have to map vaccine need with infrastructure, so that to deliver it. For instance, one of the big ones is cold chain requirements, and in many parts of Africa, really, we've been able to roll out AstraZeneca and Janssen, which require much less cold, which have much less stringent cold chain requirements. They can sit in a fridge of 2 to 8 degrees, like fridge in the house. Things like vaccines like Moderna have much higher requirements. They require -20 degrees Celsius. Pfizer -70. So when you think about it, how do you distribute these vaccines in parts of northern Kenya or parts where electricity isn't reliable? So some of these considerations need to be available, but do decision makers have visibility on where electricity is available, where we have such cold chain and others? We have to track advanced events following immunization and support reverse logistics, meaning returning, some vaccines so that it's handled adequately. We have to think about, for instance, things around delivering vaccines out of the usual, vaccination infrastructure around mother and child health clinics. We are vaccinating people who don't routinely go to health facilities. So such things. So really data becomes critical to help us optimize this logistical and other barriers. So this discussion will focus on how data has been collected and relate to decision makers, how whether we've had accurate data, are our data collection approach is optimal, is it flowing appropriately from health professionals, decision makers, etc., etc. And we will be looking exploring some of this in our panel presentations as well as the Q&A that follows thereafter. Maybe just before I introduce our panelists, I just wanted to mention that this meeting is being recorded and will be availed afterwards. And then we will have some opportunity to ask questions through the chat. But yeah, so feel free to ask questions through the chat. We may not be able to unmute some of their video unless probably granted permission by the facilitators. So really, maybe let me get out of the way now so I can introduce our panelists. We have 2 panelists now and one who will come after the Q&A session. I'll introduce the 2 now. The first is Dr. Anthony Veyange, who is the Executive Director of the Partnership for African Social and Governance Research. And I'll just do a very small introduction of him, and then he will, tell us more about himself. He's a Tanzanian development economist, with diverse research and policy interests, including inequality, poverty, health and education, agriculture, natural resources, trade, economic growth, and broad development in Africa. And so I'll invite, Anthony to go ahead and, talk to us, and then thereafter I will introduce the second panelist.
Okay, thank you very much, Dr. Njogu. I won't try to pronounce your other name. I suppose I don't have insurance. My insurance doesn't cover for that. But Dr. Njogu, Dr. Frida would suffice, yes. Good afternoon, good morning, everyone. Well, where do I start? So I am NIERA, I am Pasca, I'm an African, I'm a Tanzanian first, East African second, African third. I'm very much interested in this conversation, and I think it's very, very timely for one key reason. It's now being driven by the Africans. Us as Africans, spearheading conversation around vaccines distribution. What are the challenges? What are the issues? What is it that we can do? This is what I usually call forming or forging strategic partnership to understand and come up with ideas that are African-centric. So well done to your good self, Dr. Njogu, and Amos and team at NIERA for coming up with this webinar. Now, I don't want to go into who I am, really, because I think Dr. Njogu summarized briefly, but I want to sort of talk a little bit. I don't know whether I can talk what I want to say, Dr. Njogu, with your permission.
Yes, I don't know what you want to say, but yes, the floor is yours. Okay,
I just wanted to reflect a little bit. You mentioned a few things in your opening remarks about the challenges around vaccines distributions, the logistics. I like one of your sentences. You said, where do people are? How do we map them out? How do we identify them? And my initial submission, or rather my initial remarks, wants to focus on 2 areas. What are the solutions to the challenges that we are facing? I think the conversation that we are having right now should also largely focus on the solutions that we can actually come up with. To what extent what we do, how we do matters to the policymakers, to those who are involved in the process of vaccines distribution in Africa. So I want to start off with two key areas. One is I'll divide my submission into two parts: the supply side challenges, some of which Dr. Frida has alluded to, and the demand side. And where do we see this challenge in terms of vaccines distribution in Africa? So on supply side, one point that Dr. Frida mentioned is infrastructure. How do we move vaccines from point A to point B, let alone the complexities that come with vaccines conditions in which make them much more effective. That in itself it may not be a big issue, but the issue is how do we access those who are in the remote areas? If you look, for example, in Kenya, if you look at the county distribution of vaccines distribution in Kenya, Nairobi is leading, the neighboring counties are leading. But if you go further away from Nairobi, vaccines uptake and distribution, it tends to also sort of hyperbolically decline. And sometimes one would wonder why. So there are so many things that one would think about. And most often we tend to think of vaccines distribution, we think of people who are in urban areas. We need to think of people who are in the countryside, who are where roads are hard to connect, where networks are hard to connect. So from this point, I look at vaccines distribution as a multi-sectoral problem that requires all of us, different sectors coming together to think about what Dr. Frida said, electricity. If you want to store these vaccines to meet the minimum conditions that are necessary for it to be effective, you need electricity. So where are the Kenya Power, for example? You need to have proper roads, Kenha, and access. You know, the issues to be security. So infrastructure and logistics are very, very key. I want to also talk a little bit on the supply side on technology. How do we use technology to address vaccine distribution? I want to allude to one very good example. When COVID hit the world, South Korea, the way they were able to use artificial intelligence and machine learning to try to map out and isolate cases of COVID-19. I mean, technology has actually worked magic for South Korea in the beginning. It really was able, the government was able to isolate those who were detected remotely and be able to actually minimize or contain the spread of the pandemic. Now, to what extent are we using technology? Technology is key. People have mobile phones, the same way we have M-Pesa all over Kenya, all over, penetration rate is very high. So can we do the same? Is there a way that, are there innovative ways that we can use for people, especially those in remote areas, to be able to be reached out, to be mapped properly using the appropriate technologies? And technologies here, it could also be what Frida said, mapping. It's one thing to know, to have vaccines, another thing to know where these people are on the supply side and whether they are accessible and how reachable are they. The third element on the supply side I want to talk about is what I usually call, and in PASCA, it's one of our very famous theme, social protection, Afrocentric social protection. How do we provide social protection that takes care of especially the most vulnerable in the society? And in this case, if we think of COVID-19, as we all know, the elderly are very vulnerable. And for me, I look at vaccines distribution and access as a social protection issue. You can frame it along those lines, especially for elderly who can't go to the hospital, who are scared sometimes to go to the hospital. Not because vaccines are not there, but because they feel vulnerable. You know, so how do we help? Do we need to think of digital ways? I don't know whether we can vaccinate people digitally, or do we need to empower and use community health workers? Do you need to use the communities across the countries in Africa, within and outside the places where the urban cities? How do we tap them to help the distribution be more efficient and effective to reach those who are needy in the society? And the last bit that I would like to talk about is how do we use data? Because to be able to reach to these people, to be able to reach out to those who are targeted, you need to be able to have good data that is credible. So maybe we might talk about how do we collect data, how do we analyze, what are the methods, and so on and so forth. But I think good data, data-driven evidence is key. And this is needed both not only from public health specialists or medical doctors, also government for policy making to understand the skewness, the distribution of these vaccines. Is there some form of inequality? Because if not done right, again, it can propagate poverty, it can propagate inequality in different ways that we might not be able to tell now, maybe might be able to associate and attribute to later in the future. So that's the supply side that I sort of wanted to talk about in terms of the solution. Now, on the demand side, I have a few points to mention here. The first important thing that I think is very critical is trust. Building trust. We have had misinformation about vaccines because the demand says the uptake now. You can actually have proper network, infrastructure, and logistics to get vaccines to where they're needed, but people will not be able to actually come up. We have had in developing economics, we have had studies that have looked at the extent to which why households do not respond to vaccines, for example. And on the demand side, there could be a lot of incentives. One of them that has proved to be the deterrent of people to responding to vaccines is trust. If they feel that these vaccines, especially with the ongoing misinformation about vaccines, about hidden agenda and so on and so forth, that derails people's trust, takes away their confidence in the vaccines. So even if the supply side works well, there's a need to think about the demand side, building trust in terms of addressing vaccines hesitancy and skepticism, building trust even on the vaccines themselves. The Moderna, the AstraZeneca, someone says the Moderna is better than AstraZeneca. I mean, Pfizer is better than I don't know, I can't even tell the different types of vaccines that we have. So do people have confidence in these vaccines that they're being produced? That's very important. And that credibility starts not only from the WHO, from the multilateral level, it also starts with the governments. It starts with the public health institutions. People need to be able to believe and trust that these vaccines are good and they can help us. The other point on the demand is to create awareness. And awareness here is actually, it requires data because we are not talking about propaganda. We are talking about evidence-based awareness. You really need to have evidence of what is working. Where I was reading an article today, the Daily Nation, and they were talking of vaccines uptake in Kenya for elderly people who were the priority. Unfortunately, the uptake is very low. It's only 55% of the elderly people who are able to take up vaccines. And if you look at the distribution across the different counties, you can see a lot of nuances that could actually reveal a lot of information. Perhaps Nairobi is much more concentrated, communication and awareness is well spread, but maybe in other counties it's not the case. Do we need to think about different channels and mechanisms to deliver messages? Perhaps if Janine was here, Rwanda was very successful in that regard. Perhaps other countries need to learn some of those lessons on how do you create right information awareness on vaccines, access, and also effects if possible. The other thing that I wanted to talk about, the last two, distance. How do we access? We have in the economic literature, we have had studies that have shown distance to health centers can actually be a big predictor of access or rather uptake of some of the health interventions. The studies have been done in India, in Africa, confirming such a hypothesis. To what extent, again, right now we are being told the vaccine center is in this place, is in that place. Maybe it requires people to move, and to move, it has an economic implication. People have to pay fare to get there. Perhaps thinking about taking it closer to people so that uptake becomes easy. And finally, the social norms. How do we rally around social norms? Social norms vary across countries, across counties, and people's beliefs and social ways of doing things can be a very big predictor of uptake of vaccines. So it's not only the demand, the supply side, it's also the demand. So in conclusion, Dr. Frida, what I want to say, when we think about vaccines distribution and its challenges in the continent, we also need to weigh in both the demand, the supply side, and probably the exogenous and endogenous parameters that we may not be able to observe with our eyes. Thank you.
Thank you very much, Dr. Veyange. That is a very, interesting discussion. You brought up quite a few points. I think many of us think of the supply side challenges, the infrastructure, and so on. But even on that side, you've actually highlighted the value of using technology. Can we use that to show us where we should be delivering it to? issues around social protection. So I think that was very interesting, but I was also happy to hear you bring up, the demand side issues, because that is still part of distribution. It is not distributed until the vaccine center, but until it's in somebody's arm. So, the issues around vaccine and how you can use data to fight misinformation, but also information just to ensure that the process of getting access to the vaccine is as painless as possible. So thank you very much. That has been very, very informative. And I'm sure there will be getting a few questions on that, around that, some of the points that you've highlighted in the questions. At this point, I want to invite our second panelist, Mr. Samuel Muhala. Mr. Samuel Muhala is a Monitoring, Evaluation and Research Manager at AMREF Health Africa. He is also the Technical Lead for Research and Innovation at AMREF, providing policy guidance and implementation to their research strategy in Africa. He's also the M&E Research Manager, leading a strategic information and research functions for the $35 million annual average budget for their country programs. He's also a spring semester visiting research fellow at the University Berkeley, and he sits in various interagency coordinating committees and technical working groups at Kenya's Ministry of Health. So karibu, Mr. Muhala.
Yeah, thank you very much, Dr. Frida, and thank you for that introduction. It's always a challenge to come after Tony, because he's I would say, a good speaker that some of us would want to match, but still. So, Dr. Frida, I wanted to share some slides that I prepared, and I see the host has disabled that. I don't know whether you can enable it.
Maybe Lorraine, are you able to assist?
Yes, you can now. Yeah.
Oh, okay. Now it's okay. So quickly, I prepared some slides which will just guide my what I'll be talking about. And it's good that Tony has highlighted what I'll be focusing on mostly. That is the demand side of vaccine distribution. But let me start by giving a brief background of where we are now with the COVID pandemic. WHO declared COVID global pandemic in March 2020. We all know that. By the other day, that is 15th of November, we had a total of 8.5 million confirmed cases and more than 220,000 deaths in Africa. And the Economic Commission for Africa has projected that by end of this year, if the impacts of COVID-19 pandemic are not managed, then we'll have more than 500 million Africans going into extreme poverty. And that's a whopping more than 37% of the African population. So you can see this, and end of this year is just a month we are a month to the end. So we need to do much more to ensure that we get vaccines to our people as much as possible. And even questions have started to emerge on whether African countries will be able to meet their SDG targets by 2030, because already there is a serious slowdown in terms of achieving those targets. And so safe and effective vaccines are critical to ending the pandemic. And so if you look at Africa, already 50 countries have received vaccines from COVAX. About 300 million doses have been supplied to Africa, and 59% of that has been administered to people's arms. And as Dr. Frida did mention, just 9% of our population are partially vaccinated, and only 6% are fully vaccinated. Again, as a target of 40% that we need to hit by end of this year. So you can see that gap that we need to bridge by end of of this year, a month to close of the year. So one of the major challenges that I picked, or the challenges that I picked are high levels of vaccine hesitancy and low trust among our communities in Africa. And this stems from misconceptions and myths that are fueled by misinformation about the vaccine. If you talk to the people on the ground, you'll be able to pick some of the things that they think about the vaccine. Those who are on social media, you've heard people talking about vaccines and how it delays periods among ladies, whether this vaccine would lead to infertility among men. So there are there's so much that is going on social media that is misinforming people, and that is leading to high cases of hesitancy and low trust among our communities. So we conducted a study at Amrefelt Africa on hesitancy among the youth, and I picked that to narrow down and just to bring out the picture on some of the things in terms of evidence that already coming out, leading to hesitancy. So we found out that about 58% of our youths are hesitant of taking this vaccine. And this is higher among female youths. It's also very high among Protestants, if you look at religion, and those with post-secondary education. And if you look at the next, social media as a source of information contributing to hesitancy, and you relate that to post-secondary information or education, because you find those are people who are maybe spending much more time on social media and able to read what is happening in there. There's also a lack of information and concerns around vaccine safety and effectiveness, mainly, which is leading to hesitancy. And other contributors to these are low trust in the MOH and belief that mass vaccination is not helpful. We also looked at how the community health workers, what they think in terms of whether they're hesitant or not, because community health workers are very important when it comes to mobilizing communities to take up some of the health issues that are being that are being promoted. So we found 19% hesitancy across the country, but with a wide variation from among the counties that we have in Kenya, from 9% to 41%. And the determinants of hesitancy or predictors of hesitancy among this group are safety concerns, trust in MOH, again, coming up among community health volunteers, vaccine manufacturers, and the source of information that they get to, whether it is through MOH or through radio stations and the likes. And so hesitancy among community health workers is really likely to negate the impact that of the COVID-19 vaccine rollout, because they are like our community gatekeepers. They interact on a day-to-day with our communities. I also picked a study by WHO, and it looked at the population in Namibia, again on hesitancy, and it says that a third of the population or in Namibia are unwilling to get vaccinated because of safety concerns. So you can see that from those two countries, hesitancy and trust, as Tony did mention, is a key problem that we need to manage across African countries for us to ensure that we are able to roll out or distribute vaccines properly. And so there is this paper by Noni, and he tried to look at or come up with a vaccine hesitance determinants matrix. And if you look at it, they're more or less the same things that were coming up from the two studies that I've shared. The broad areas of determinants to hesitancy around contextual issues. And these things to do with communication and media, the media environment, whether the use of influential leaders, our gatekeepers, historical influencers, religion, politics, geographical barriers, and perceptions of pharmaceutical industry. So those are contextual issues that affect or that determine the rollout of vaccine or hesitancy among our communities. The other broad area that is a determinant to hesitancy are individual and group influences. And these are like personal or family experiences with vaccination, beliefs, attitudes about health and prevention, knowledge and awareness about some of these issues that you're talking about, the health system and providers, trust and personal experiences, and immunization as social norm versus whether this is not needed or harmful. Those are determinants that are really key when it comes to addressing hesitancy issues. And then the third broad area is those specific on vaccine or vaccinations. And these are issues that are directly related to vaccine or vaccination. And here we are talking about the risks or benefits, the introduction of a new vaccine, or whether it's new or something that has been in the market, the mode of administering this, the design of vaccination programs, whether there are schedules, and even costs that come with the rollout of vaccine programs. So these are metrics that when I looked at it, it more or less speaks to what we came up with in the two studies on hesitancy that conducted among the youth and among the community health workers in Kenya. And so what are some of the key lessons that we pick? And here, these are some things that came from Organization for Economic Cooperation and Development on their response to COVID-19. And the first thing is that we all agree that the development of vaccine has been an extraordinary success. Because if we did not have vaccines by now, we would still be in lockdowns in our countries. And most of the things that now have opened up would not have happened. So the development of vaccines has been a great success to date. And so trust in vaccination and in the ability of governments and partners to communicate and to successfully deliver a vaccination program is critically dependent on the extent to which the governments and partners can instill and maintain public confidence in the effectiveness and safety of the vaccines. So same what Tony was talking about, the need to build public confidence in our communities. Number two is the competence and the reliability of the institutions that deliver the vaccines. That goes towards building trust, the capacity and the effectiveness of regulatory agencies in handling issues and communicating consistently as events arise. So like during vaccinations, if adverse events happen, how are these managed and how is this even communicated to the public so that to build that trust and confidence in the program that everything is okay. And is also development took place It's important for governments to emphasize that no development and regulatory corners were cut in the process. And again, that goes into building people's trust, because you hear people saying that the speed at which this was developed, they can't really trust that it will be of help to them. So we need to address that and communicate strongly to our population so that we build that confidence. And evidence is needed on different populations, specifically on areas of specific concern, their prior experiences, both with vaccination and the health system in general, religious and political affiliations, and socioeconomic status. These are some of the predictors that you saw in that matrix that are important in terms of addressing the issues that we experience in the community. And this is important to do in specific communities. You will not find something that worked in, for example, in South Africa, you copy paste the same in Kenya. We need to find out the specific concerns that our communities are concerned about, and be able to tailor that, use that to tailor vaccine programs for purposes of rollout. And then lastly is on strengthening and implementing communication strategy for public education, awareness creation and management of misinformation on COVID-19 pandemic. There is that need to proactively release timely information on vaccination strategies, modalities, and accomplishments in disaggregated form and user-friendly way that most of our communities and people on the ground are able to relate with. And there's so much information, both on physical and social media, what we call infodemic. So we need to enhance transparent and coherent public communication to address misinformation that comes from social media and physical media. And there's need to engage the public when developing vaccination programs and the form and content of key information. Because if you bring something that the communities don't participate in, you may find resistance from those communities. And those are the things that we need to reduce on so that people don't resist on the vaccines that we share with them. Thank you, Dr. Frida. That is what I wanted to share, and I'll be happy to pick questions. Thanks.
Thank you, Mr. Muller, for that very engaging discussion. And this was really a deep dive, especially into the demand side, challenges or things, considerations that we should have as we try to drive vaccine distribution and also uptake. I was quite, I was quite intrigued by some of the things that you talked about, especially who is being hesitant, female, youth, post-secondary education. I mean, it's really good that we're able to map who those are, and if possible, map where they are, as you share some information showing the geographic variation in where they are, so that we're able to target our interventions or communication. I think that's very useful, so that we're actually using even as granular data as is available to design our interventions. Also, just very interesting around the qualitative data that you provided around the determinants of hesitancy, so that actually we are, while these are broadly about vaccines, I would assume that quite a few of them would still be relevant for COVID, so that even as decision makers in government or partners, media, we are actually able to use that information to actually target our programming or our communication, etc., etc. So I think that was very, very useful. I'm sure. So we'll go into the Q&A section right now. I'll be checking to see what chats we have. Please post any questions you have in the Q&A section. But even as we start out, I want to start us off with one question. So a lot of this data has been provided, so we know what are the demand side barriers, what are the supply side barriers. So one of the questions to Dr. Anthony, how do we increase evidence uptick of vaccine research in Africa? How do we ensure that that information is actually being used, not just available, but being used? Yeah, if you could go ahead.
Okay, thank you very much, Dr. Frida, for that question would require maybe a whole day to discuss, but I'll try to make it very short. And I want to use one framework to make participants understand, and I'll be selfish. I want to use PASCA's framework. And in PASCA, we have what we call utafiti sera. For those who don't speak Swahili, utafiti sera is a Swahili word which means research policy. And in utafiti sera, we have 3 layers. When we think about evidence uptake, regardless of who is on the demand side, on the receiving side, policymakers, policy actors, we call them policy actors. One, we believe that evidence should not be extractive. Most often when research is designed or when evidence is designed for data generation, for policy information, it tends to be extractive. You use those who are targeted passively, okay? So first of all, our philosophy is evidence is not extractive. Second is demand-driven, okay? Demand-driven in the sense that in academia, researchers will sit in their offices and they would want to say, well, this hypothesis is very interesting. I want to go after it. And so come up with some knowledge frontiers. We don't believe that. We believe we focus on the problems on the ground and try to design research that speaks to such problems. With these 2 caveats in place, uptake becomes easy because you have policy actors involved, and by policy actors, we mean governments, we mean social, civil societies, we have private sector. These are the people who know the issues that the society is facing. And if you're framing evidence generation around those issues and they are part and parcel of the design process, then obviously you can actually achieve what you want in terms of evidence up. So the first and foremost is to make evidence generation as participatory and engaging and accommodating as possible. That's number 1. But number 2, how do we unpack the data? Because we can talk about qualitative data, we can talk about quantitative data, but how do we unpack the data to actually tease out the lessons that are coming from the data is also another area that is also very, very important. And I think as researchers, we need to be broader in terms of the information we are collecting, but also very granular and specific to the issues that we're trying to address. Unpacking the data and communicating and packaging for convincing others. It's very important because you are technical. How do you make it easy? How do you make it digestible for someone who is a non-technical to understand and be convinced that this research has had an impact? The last bit that I wanted to say is how do we make the data credible? Transparency in the way things are done. And this, we have seen this movement coming along. In the West, it's actually caught up now, where transparency and reproducibility is very key. Can we replicate your study and see the same results? Oh, you p-hacked, they call p-hacked, and then anyone else cannot see the data. So credibility of the data, credibility of the process is very critical at influencing people to take up the evidence that is being generated. So in short, one I said is make evidence generation participatory in as much as possible. 2, communicate well and credibly and clearly and coherently for even a layman to understand. And the third element, I think, is credibility around the way we do research, the way we do data collection, the way we do everything related to research from the beginning, from the design, all the way to analysis, evidence, and communication. Thank you.
Thank you very much, Doc. Very interesting. Just showing that it's demand-driven. I think a lot of us researchers tend to, research on something that is very interesting to us that may not necessarily be the case with the decision makers and so on, and ensuring that it's credible. I have a question around that, but before I do, I want to introduce our third panelist, who will not make her presentation now, but she maybe could take some questions and then later on do her presentation. Our third panelist is Dr. Janine Kondo. She's a medical doctor and associate professor of public health. She's a CEO at the Center for Impact, Innovation, and Capacity Building for Health, Information Systems, and Nutrition. And that organization, CIICHIN, is a nonprofit registered in Rwanda. She also, as I mentioned, she's a adjunct professor at the University of Rwanda and Tulane University. And she's previously held, numerous senior government posts at the University of Rwanda and the Ministry of Health. And she's also the former Director General of Rwanda of the Rwanda Biomedical Center. So welcome, Dr. Janine. I will invite you to participate in the Q&A, and then later on you will do your panel presentation. So just going back to just the questions that Doc was answering, around how to ensure that there's increased uptake of evidence on vaccine research in Africa, and he's addressed quite a few things. But I was going to ask, we researchers tend to publish in academic journals. We tend to use, p-value, just quite a few things that may not necessarily be very useful for decision makers. How do you propose that we package this data so that it's actionable and so it moves from being very academic to now being, relevant to the specific policy, makers in government, but also to various implementing organizations? How do we package, very rigorously, generated evidence for use by media houses, because they're definitely not necessarily researchers themselves, but also they're communicating to a population of laymen.
Okay.
Then we also have Dr. Maybe Dr. Veyange can take that, then maybe Dr. Janine can also say something about it as I get up the other questions.
Okay, thank you. I'll be very brief. How do we package? That's very important. And that's the challenge, especially in academia. That is actually at the center of the disconnect between research and policy. Because if you write in an academic sense with a lot of P jargon, P hacking, P values, statistical significance, nobody cares really. In the policy space, they want very easy, straightforward, digestible messages that can make sense. So one of the areas that is very critical for researchers is to build the communication capacity, the ability to communicate. And there are many ways of doing this. And for example, in my experience of doing research, when you write an academic paper, you need to work with communication people. One way is to write a policy brief. Another way is also to use infographics. Sometimes when you write with all the regression tables, no one really understands, but can you extract the key messages and use visual appeals to show so that people understand what is your key message. One thing that I've seen, especially in Africa, that has a huge impact on policy when evidence is also to use African-based data. There are some countries, for example, if you don't use their data to actually communicate, that evidence will not find its place in the policy space. You can publish in an academic journal, but policymakers won't listen. So using their data, packaging that information, using visual appeal, using social media very well, sometimes complementing with human stories that relate around that subject you actually did, also has an impact in terms of making sure policymakers understand. And always remember, for those who are doing research out there, when you go to policymakers, you need to be in their shoes. You need to learn to see how they see the world. But if you go there and you want them to see the way you see the world, obviously they won't. So it's about understanding the culture, the environment within which policymakers work. In PASCA, we do have that element. Our research team is actually doing a study on policy cultures to understand it's not only uptake of evidence, what are the behavioral norms and responses that we need to know? If you've followed very closely a frontier on impact evaluation, it has moved away, not only documenting impact credibly and rigorously, but how do we infuse for people to use that evidence to make policy decision. And this is where you have had methods like contribution tracing, priori analysis to understand behavioral response of policymakers. It's very important to have those in mind, because it's not only the packaging is good, communication is good, but understanding the environment within which such research and evidence will interact with policymakers is key. Thank you.
Thank you very much. I don't know if Dr. Janine would like to add something to that.
Thank you so much. Hi, everyone. Always good to be part of this interesting webinar workshop, but also good to hear from my friend and brother, Anthony. I wanted just to emphasize a couple points, on top of what Anthony said. I think sometimes we academicians and researchers, we think that policymakers didn't go to school. Why I'm saying that, you have very good policymakers with PhD, just they don't have time, right? So I think we are a bit selfish. One of the ministers here in Rwanda used to say academicians are like a parasite. You wait until you come and phagocyte and so forth. So I think something that we've been missing as academicians is, involvement of policymakers from day one, right at the start of the setting of the goals, research questions. I'll give you an example, something that we are doing here, evaluating the lab systems with our Gates Foundation funds. Even in COVID crisis, the DGs, the minister will have 5 minutes for us. And I'll ask them, those are the questions that I have. Do you want to have another question? Do you want to add another question? The more you involve them, and something that I don't leave it out is asking if I can report to them on monthly basis, on quarterly basis. I demand for that. Hey, you need to know what we are doing. I need to report back to you and to tell you where we are in terms of the results. By involving them at every single step, you have also the buy-in. The second question is, it's not about me telling you what to do, it's about communication, as Anthony said, the formal and the informal platforms. I think we missed that. We think that formal platforms are the best, but I think most of my messages pass through when it's informal. A WhatsApp message, those are the questions. Can you respond quickly? Can I see you after work? Can I grab him in the parking? I asked him, hey, you remember the study that you're doing? This is what we are funding. Do you agree? So I grab both formal and informal communication to grab their attention. They're so busy, they don't have time, but at the same time, we need them to have a time for us so that they can use the evidence. Most of the time, there's disconnect between what we fund in the research and what is actually being implemented, if not many reports that we put in the drawers. Lastly, is who set the agenda? Who sets the research agenda? Right now, I'm co-chairing an ITAD subgroup on who we fund, again, from Gates Foundation, on who actually set HSS, health system strengthening, in Africa and most of the developing countries. People come with their research agenda. And most of the time, we academicians, we go where money is. If you ever think about how can we generate research questions from policymakers and turn them into grants, into funding, instead of the other way around. Someone comes with research question and he or she comes with money. So as most of the policymakers, we don't have enough money to implement what we're supposed to do, as well as doing research. So I think we need to start rethinking the way that academicians are actually helping the policymakers in the way that is supporting them. So those are the questions for us as academician researchers to see where we want to be and how actually we can help within the means that we have. Over to you. Thank you.
Thank you very much, Doc.
Can I add?
Yes, please go ahead.
Right. So I just wanted to emphasize on what Dr. Janine has mentioned by giving an example of what we have done at AMREF. We set the agenda, research agenda, to be around COVID-19 the last 1.5 years or so. And we've seen this really working well in that the researchers and the policymakers within the organization have been just interacting to try to see the direction that the COVID pandemic is going and trying to come up with such priorities well in advance, and even putting in funds into those so that people can develop research projects around that and be able to connect and share. And so we've seen this really being working well in that some of the papers or the researches that we've done and shared out there have made us to be thought leaders in the vaccine program. And we've seen a lot of organizations coming in to ask, can you guys be speakers in this? Can you partner in these projects? And so what I'm driving to is that is one of the positive things when you're able to churn out evidence that is credible and people are able to relate to it, and even communicate this in a manner that everyone, different audiences can understand. You tend to get more and more stakeholders coming in asking you for partnerships and even more money coming in. So is one thing that as researchers we can look into as our organizations, coming up with clear research agendas and just following that to the point of even dissemination. Yeah.
Thank you very much, Samuel. And just talking about how how we're able to present the data and also even become a thought partner, as well as what Dr. Janine talked about, setting the research agenda and so on. So Samuel, my next question is actually tying that up and also just linking it to another question that has come in terms of, so we have very many people, very many research, many organizations, all of us here doing research. It's sort of tied to what we've been talking about, how to get it in front of decision makers, but how do we ensure that it's available to them rapidly, so that, and also how there's many of us, there's IDinsight, there's AMREF, there's all of us doing this research. How do we ensure that it's not competing, but it's useful to them? What is the role of, for instance, the technical working groups that you sit in, or rapid evidence help desks? Are those opportunities that we can explore? Maybe you could talk about that, then I will go to another question on vaccine, on equity.
Yeah, thank you very much. I think what we do in research should be able to inform program. And programming, for example, around COVID-19 is led by the Ministry of Health. So the Ministry of Health defines the agenda. So all the research organizations that play in that sector should be able to find something or somewhere to plug in. If you look at it, we are not yet churning out enough research as compared to the West, the Western countries. So we should not look at it as competition as such, but we should look at it from the relevance point of it. Is this relevant for us? Is it something that will be able to benefit us now? And is it coming out? Are we able to produce the findings faster in a manner that policymakers, including the Ministry of Health, would be able to make use of it to inform the next programming or the challenge that you're facing now? So we have the technical working groups, for example, on research, on COVID response, and a number of partners are there. So those who find themselves at the table would are aware of where the discussion is headed to, and they're able to do that. But not all of us are able to participate in that technical working group. But that should not hinder us from doing research. We need to do more and more so that we produce the evidence that is needed. But not only that, how we communicate it is important. We need to be able to, we should be aware of our audience. When you are speaking to researchers, yes, no problem talking about p-values. When you are talking about to journalists, make it as simple as possible, that it can be packaged in a manner that it can even find its way into our newspapers or TV stations. Yeah.
Thank you. I agree. And I'm just also thinking that how do we then synthesize all the information that's coming from everybody, so that we're not presenting a lot of it to decision makers, but also just providing maybe like one summary. I see your hand, Dr. Anthony, but I'm just going to ask you to hold. There's a question that was asked quite a few minutes ago. I'll come back to you on vaccine equity, and I'll pose this to Dr. Janine. How did equity affect the vaccine interventions? considering the global north delayed the supply to African countries, or the global south more broadly, till they fully vaccinated their citizens. But I'll expand it just beyond really how it affected that, but also what we should be thinking about moving forward in terms of vaccine equity, both global north versus global south, but also within our countries. Yeah, Dr. Janine.
Thank you so much. This is a tough question because it's all about how we are viewed, right? Something that I discussed with Sam long ago is about decolonialization of global health. So this is something that has come now strongly as we are navigating through this pandemic. We do teach as well on this. I think the concept is not well understood by everyone, especially when it's come to the decision of who has access to what, who has right to health services, and so forth. Unfortunately, there are numbers of platforms that were put in place, including COVAX facilities, to facilitate countries like ours, African countries, developing countries, to have more equitable vaccine, but also distribution. So I think here we are talking about two words, north-south, but also south-south. North-south, there's a fact there. And as you can see, in some part of developing countries where you see, actually vaccines going up to the expiration, where here in Africa, we are still queuing to get vaccines. So I think a call it's all of us call, but more importantly, to all these funders and philanthropists, WH and others, to see how actually countries, presidential diplomacy and everyone should take responsibility of not only the population where they are governing, but also beyond. Because as you'll see, we don't know about the COVID yet. We don't know. We are still struggling about different variants, and probably in a few months, we are approaching December, we may probably have another peak. As soon as you have peak in Europe and US, in a few months you have it here in Africa or in India. So meaning that it's no longer about me, myself and my vaccine and my family. It's actually about the global family. So I think time has come that every leader across the world should understand that if you don't protect your neighbor, actually you are hitting yourself back. The second point is now, once you have that small dose or those small doses of vaccine, what do you do with it? How do you ensure equity? I think it's important to learn from each other. I think studies that were supported by ARC, at that time it was Anthony, who requested researchers in Africa, in East Africa, to actually understand what is happening in terms of readiness and so forth. So what you're finding, there is a problem, not only global to south, but also south to south. How a country actually use efficiently and effectively the vaccines that are available. How do you choose who should have access to vaccines? I think those are the important points that every single leader, when you say leader, it's not only at highest level, leader where you are. How do you support? How do you help identifying who is at risk? How do you first prioritize those who are in need? I think those are the questions that we need to ask ourselves to assure that equity is respected. I'll give you an example of Rwanda because I live here and also I know more or less what is going on. The first, I guess also that happens also in many countries. To ensure the equity, first we look at the data. Data again comes back again where researchers are needed. We looked at the data and see who are being vulnerable to COVID, who are dying from COVID. The first thing came was old men, diabetes for some reasons. Those who had diabetes, and probably because of when you have COVID and when you're putting in the treatments, it exacerbates as well your sugar in your blood. So it creates and induce diabetes anyway. So based on those figures, you now look at your vaccines availability. We only had those number of vaccines that were available to us. So what you need to do is first you protect your frontline providers, not only health provider, but also those who work at the immigration, those who work at the airport agency, everyone who is in contact with many people at the same time. And then we move on to those who are the elderly and also those who have issues. And then, people like us, I consider myself as a youth, young people, people like us can hold on a bit before they get vaccinated. So I think it's all about not only human rights, but also how the country manages this doses that we have for equitable population distribution. I don't know if I respond to the question, but I think it's a little bit more than a few words that I want to say today. Over to you, Frida.
Yeah, thank you very much, Doc. And I agree. I mean, these issues of so we need to move towards decolonizing development broadly beyond even COVID. But it's a pet subject of mine. I will not go into it now. But I'm agreeing that data and evidence can help us even think through this beyond even analyzing who is So I think you've detailed quite a few of the considerations we should be having in terms of who's in intra-country or inter-regional variations in terms of access. But beyond even that, we can also think through who is getting the vaccines. Can we disaggregate the data by gender, by geographic, whatever, by socioeconomic status, by ethnicity, just so we are seeing, is everyone getting it? Often I think the elite tend to be the first ones to get it for whatever reason. So I think data can actually help us in many ways. I know we are almost out of time for the Q&A. I want to go back to Dr. Anthony. One, you can comment on what you had a raised hand, so you can talk about something, but also you can answer our last question. How can we use research to ensure Africa is independent in vaccine generation? I know you're an economist, and if maybe I'll probably ask Dr. Janine to also jump in, but I think there's also the other, from an economics point of view, because you don't just become vaccine, you don't become just capable. These investments that need to be made. What kind of policies need to be made so we're able to actually grow that kind of muscle. So I'll go to you and ask you to just take 2 minutes or 3 at most, and then back to Dr. Janine for another 1 minute before we go into our presentation. Thank you.
Thank you very much. So let me go quickly on the first question. How do we ensure research gets to policymakers? I have a couple of points here to make. One is let's create communities of practices. Okay, in Pascal we call them houses. Communities of practices brings practitioners into those houses, or rather into those communities, who are, as Janine said, from the design of the research, they are part of that process. And when the evidence is out there, they will be the ambassadors of what the research is saying. The communities of practices is very important. Let's empower these communities of practice. And as I said earlier on, they have to be multi-sectoral. It's not, it's health, then you're focusing only on medical doctors. Try to make it as multi-sectoral as possible so that you're able to capture the nuances that will come from the different sectors and different players within that space. Second is to build the capacity, because it's one thing to generate research and expect policymakers to be able to process it. I think concerted efforts are needed to build the capacity of policymakers, not only to process evidence, but also to understand and be able to think for themselves. So building capacity is also key as an ingredient of how policymakers can actually chew the research and the evidence that is coming to them. The last point is, let's make data public goods. There are so many people who are collecting data left, right, and center, but those data, we tend to hold them dear. Let them put out there as public goods. We've built the capacity of governments and policymakers. If they have access to data, while they're waiting for our evidence to come out, they can actually process them themselves and be able to act quickly than waiting until we get the evidence out. Now, on the second question on how can we use research to ensure Africa is independent? The first question that sort of clicked in my mind, do we even have that research to begin with? And I'm throwing it out there for everyone. That research in itself is a process. It's a process, and it needs effort, inputs, activities to be generated. But the other part of this question is, let's assume we have this research. How can then this research be used sort of ensure Africa is independent? First, we need to think about infrastructure that is needed. Do we have enough infrastructure to respond to these issues, to let's say COVID-19, let's say debt in African countries? How do we ensure we have that evidence, so to speak? But most importantly, the use of indigenous knowledge. I think we have been talking of so much about vaccines from the big pharmaceuticals. What about indigenous knowledge, which is cheap, efficient, and it has proved to work over centuries? So there's this hype about Moderna, AstraZeneca, and all sorts of things, but there's indigenous knowledge just around us. So let's think of Afrocentric approaches, but responding to COVID vaccines in Africa. Research also we need to think about bringing together the different thinking, the resources that is needed. Of course, you need money to do research. You need money also to invest in terms of how Africa can be independent to produce such vaccines. That, as you said, Dr. Frida, that in itself is a beast to think about. You need to set pharmaceuticals, you need to have intellectual property rights, you need to have all these sort of things that are needed as a supply side to be able to produce. But do you have the technical know-how? Do we have the capacity to help our people think for themselves and think independently to be able to generate and produce their own vaccines? What we are seeing now, and I'm concluding, what we are seeing in the West, there's a marathon. All developed countries are trying to produce their own vaccines. This is a policy question. They are trying to produce their own vaccines. In the very same marathon we see coming to Africa, we have Moderna, we have AstraZeneca, we have Pfizer, we have, I don't know, they're all rushing to bring them to us. Why can't we use our own indigenous knowledge, our own herbal medicines to think about coming up with solutions on COVID-19 vaccinations? They have worked for centuries. They can work now, but what effort are going there to help? I don't know. I'll leave there. Thank you.
Thank you. Yeah, I was about to. So thank you very much. I'm actually going to just change to shift gears. I was going to spend more time on the Q&A, but I'll ask to leave there. Thank you so much, Dr. Anthony, Samuel, and Dr. Janine. It was really good. Just getting your input on all those. Right now, I will just want to shift gears a little bit. It was good to get your responses on your presentation, but also later on your thoughts on the various questions that were raised. I think they've helped us think through a few other things, and I like the idea of decolonizing. And we have a lot of indigenous knowledge, and just really thinking, how else could this be done? So I will invite Dr. Janine to speak briefly on the Rwandan context, and how evidence-based research continues to inform policy, and specifically how it can help us in informing the COVID vaccine, the COVID-19 vaccine discussion. Thank you very much. Doc.
Thank you so much. It's been back and forth. I was just wondering, can I share like 2-3 slides? Is it possible?
Yes, it should be.
Only host can share in this meeting. And do you think you can do something there?
And you can grant her access?
I think Anne
Okay.
stepped out. We may not be able to share your slides at the moment.
Okay, it's fine. So I wanted just to talk a little bit about the Rwandan evidence. So again, as I said, I wanted to share with you the Rwandan case study, but it's fine. Rwanda is a country with, as many countries, we have pyramids that actually informs on which systems, which data, which program, which interventions at which level. So, and then what we did actually, we learned from the past, always learn from the past, learn from the mistakes, learn from the achievements. We learned from Ebola crisis, right? We learned that you need to have first your system be ready. So we went through evaluations of global outbreak indicators. Some of them are how the system can actually be able to cope with an outbreak. Are the people informed, and how are they prepared? Do they have simulation centers and so forth? So with Ebola, Rwanda was a bit prepared, learn from the Uganda and I think DRC as well, outbreak to get prepared, and also talking and exchanging information from different institutions like the Ministry of Health in Uganda and Rwanda were really paramount to information on the data. This is something that my colleague said. You need to share the data. You need to alert. You need to inform. You need to tell your colleague. You need to raise the alarm of something's happening. And then from there, we were able to create what we call COVID-19 command center. And that command center actually made us be aware that this is not a problem of health only. This is a cross-cutting problem. And we've seen that with COVID, everyone can work very well. So here, unfortunately, you can't see, but we had around 5 cells that were created. We have epidemiology and operations cell, administration logistics cell, communication cell, and plant cell. In each of those cells, you have sub cells that will inform on what is going on in terms of getting prepared with the data. What does it mean in terms of transport, equipment, materials, infrastructure, and also finance administration? How do you communicate? This is something that have been coming up, and it came so strongly during COVID that the communication cell was needed. In this cell, we have to work with your media management. You need to manage the rumors and also management of everything that can come up, across media. Also awareness and community engagement. Every 2 weeks, the ministers, be it Minister of Health, Economy, local government, they'll go out there on the radio, on the TV, informing the population what is going on. And then that's the only time that you have the buy-in. Then from there, we created, I think everyone knows about Worldometer, where you have the information posted right there in a minute. Once you have one positive case or one death due to COVID, it's posted to everyone so that everyone can see what is going on. So we created this platform that, every day, every minute, you know the total number of cases. You have how many of cases were recovered from last day or previous month. You have active cases, you have those in critical condition, and you have deaths, vaccinated, test positivity rate, and so forth. With those data, even we call it Muturage, the population, someone's living in a very remote area, as soon as that person has connectivity, has access to the internet, that person will see exactly what everyone can see across the world. With that, you bring the evidence forward so that everyone knows how to prepare. So you don't need to remind everyone, hey, you need your hand. They will demand for it. Especially during the COVID crisis, people will come, no shaking of hands. That was really great. But also, people will demand for their own temperature. Hey, can you take my temperature? Why you didn't take this person? And you see in some villages, if someone doesn't wear a mask, everyone will come to him. Why you don't wear your mask? Probably you have COVID. Why do you want to spread your COVID? So you see this engagement of population just because your media worked fantastic. And then you have the data, showing the trend. As one of my colleagues also said, creating the SAG. SAG is kind of scientific advisory group for COVID, where you have everyone, development partners, multilateral, academicians, Minister of Health, but also other ministries, all involved every day, every Friday, from 1 hour, from 3 p.m. to 4 p.m. We discuss about the data, and also we inform the cabinet what will be the decision. So the decisions are not only taken by the top level senior leaders, but also getting the data and the evidence base that guide the decisions. And then it comes to vaccination, and when we have all the combined effort from COVID preparedness, COVID management, contact tracing, and also you come to the vaccination. I think it was by making all these systems ready and available to the community, you actually starting engaging them. So that was easy to have an integrated COVID-19 data management system. And something that we learn is, the DHIS2 tool that everyone knows can be possible. Having a platform COVID where not only the provider sees your result, but also the patient or the client sees the result in a minute. So you are informed, and the other person also is informed, and you know what you need to do. As soon as you are COVID positive, the system will be activated to start tracking those who are close to you. So it goes all the way from COVID management to minimizing the risk and managing the consequences of COVID. Then it's come to the vaccine. Vaccine, we talked about the data. We talked about how Rwanda actually came up with who should be vaccinated first, but also we have leaders. I think learning from leaders have been, for me, like a key example to move the country forward. When we had the vaccine, the first thing that we did, unfortunately, you can see my slides, have a slide here with the President of the Republic of Rwanda and also his wife, Madame Jeannette Kagame, Her Excellency, both of them taking vaccines. And then a few days after, you see the ministers also giving example, hey, I'm also vaccinated, so I can't give you something that is not okay. And then that also is a message by itself to inside the population to say, hey, this is something that you need to do so that it protects you against the death due to COVID. So I think, I don't know how long I have, but I think what I wanted to share with you is the story around how
Sorry.
hello? Yes, the story around how the data, how the management, how multi-sector, and how leadership were all needed to mitigate the consequences of COVID. Thank you so much.
Thank you so much, Professor Janine. That was very insightful to hear how the government in Rwanda responded to COVID and how you base that on data and evidence. Very inspiring. This has been such a great conversation. I wish we didn't need to end it there. We could continue on and on. We've learned so much, and I think it's been very interesting for me to hear how different policymakers across the continent are relying on data and evidence, and also to have insights from all the panelists on what we can do as researchers and people who generate evidence to make it available to policymakers when they need it, and how we should take the lead in developing research questions, and how we should take the lead from the policymakers and research on issues that are important to them and have that be their priority. I'd like to thank all the participants for joining. Thank you to all the panelists. Thank you, Dr. Janine, Dr. Anthony, Samuel. Thank you to the team in NIERA. Thank you, Anne and Jennifer, and for everyone who took part in making this happen. I'd like to let you know that the recording for this webinar will be available on YouTube, on the IDinsight YouTube channel, and on Twitter as well. So follow us on Twitter to stay up to date and to get the recording. We're going to have more webinars and work together to kind of talk about the role of evidence in many different things and many different aspects, especially in Africa. And I like how Dr. Anthony started this presentation with celebrating that this discussion is being led by Africans, and we want to continue that. Otherwise, thanks for attending and have a nice rest of your day.
Thank you so much. Bye-bye.
Thank you. Bye-bye.
Bye-bye.